Good morning, everyone, and welcome to today's presentation. I'm P. Supriya, a second semester MSc student. Today, I'll be discussing premedication agents. We'll explore what they are, their importance, and the different types used in practice. I'm excited to guide you through this topic, so let's get started. Today, we're going to go over the main topics related to the drugs we often encounter in clinical practice. First, we have antipsychotics, also known as anticholinergic drugs, which work by blocking the parasympathetic nervous system to reduce secretions and other effects. Next, we'll look at antacids, which are essential for neutralizing stomach acid and providing relief from conditions like heartburn. Moving on, prokinetics and antiemetics play a crucial role in managing gastrointestinal motility issues and nausea respectively, helping improve patient comfort and treatment outcomes. Then, we come to sedatives, hypnotics, and tranquilizers. These drugs are important for managing anxiety, sleep disorders, and agitation. Following that, analgesics are vital for pain relief, ranging from mild to severe pain management. We also have antipyretics, which help reduce fever and are often used in infectious diseases or inflammatory conditions. Lastly, anti-inflammatory drugs are key in controlling inflammation, whether for chronic conditions like arthritis or acute injuries. Throughout this presentation, understanding these drug categories helps us see how they connect to the overall goal of optimizing patient care and managing various conditions effectively. Let's begin by understanding what premedication really means. It is the administration of sedatives and anxiolytics before a procedure to help reduce anxiety and fear in patients. This step is crucial because it helps create a calmer, more comfortable experience for the patient. Ideally, these drugs are given about 1 to 2 hours before induction, giving them enough time to take effect and provide the desired calming effect. Now, let's look at the routes of administration. There are several ways we can give these medications. They can be given orally, which is the most common and convenient. Intramuscular injections are another option, especially if a quicker effect is needed. Intravenous administration provides rapid onset and precise control, making it useful in many cases. Intranasal delivery is also an option, especially when avoiding injections is preferred. Lastly, dermal or transdermal routes can be used, though they are less common in this context. Moving on to the goals of premedication, we can divide them into primary and secondary objectives. The primary goals are to achieve anxiolysis and sedation, meaning we want to reduce anxiety and help the patient relax. We also aim for analgesia, so the patient experiences less pain, and amnesia, so they won't remember the procedure if possible. Additionally, an antipsychotic effect is desired to reduce salivation, and maintaining hemodynamic stability is vital to prevent fluctuations in blood pressure or heart rate. The secondary goals support the overall process. They include facilitating a smooth induction of anesthesia, making the transition into anesthesia easier and safer. Premedication can also help with post-operative analgesia, providing pain relief after the procedure. Another important goal is to prevent post-operative nausea and vomiting, which can significantly affect patient comfort and recovery. In summary, premedication is a carefully planned step that sets the stage for a safe and comfortable surgical experience. It's about balancing effectiveness with safety and tailoring the approach to each patient's needs. When considering premedication, there are several important factors to keep in mind. First, the patient's physical status plays a crucial role, as it influences how they might respond to various medications. Age is also a key factor, since different age groups can have different sensitivities and risks. Additionally, assessing the patient's level of anxiety and pain helps us tailor the medication to ensure comfort and safety. The type of surgery being performed is another critical consideration, as it can affect the choice and timing of drugs. We also need to look at the timing of the surgery to plan the medication administration effectively. Lastly, a thorough review of the patient's medical history, especially any drug allergies, nausea, or vomiting, is essential to avoid adverse reactions. Now, moving on to antipsychotic or anticholinergic drugs, they are primarily used to decrease salivary and mucosal gland secretions. This reduction helps improve the surgical field and reduces the risk of complications related to excessive saliva. Two common drugs in this category are glycopyrronium bromide and atropine sulfate. Let's focus on glycopyrronium bromide, also known as glycopyrrolate. It has several important uses. First, it's used as a premedication when we want to achieve antisialogog effects, basically, to dry up the mouth and reduce secretions before surgery. Second, it's used to protect against peripheral muscarinic effects of anticholinesterase, which can cause unwanted side effects. And third, it's effective in treating bradycardia in anesthetized patients, helping to maintain a safe heart rate during surgery. Understanding these roles helps us optimize patient care and improve surgical outcomes. Now, let's look at the chemical nature of this drug. It is a quaternary ammonium compound, which means it has a positive charge that helps it stay outside the central nervous system, reducing potential side effects. The presentation form is a clear solution for injection, containing 0.2 milligrams per milliliter of glycopyrronium bromide. Interestingly, it's also supplied in a fixed-dose combination that includes 0.5 milligrams of glycopyrronium and 2.5 milligrams of neostigmine per milliliter, which can be useful in specific clinical situations. Moving on to its main action, this drug is classified as an anticholinergic, mainly working to reduce secretions. This antisecretory action is especially helpful during anesthesia or surgeries to keep the airways clear. So, how does it work? It acts by competitively antagonizing acetylcholine at peripheral muscarinic receptors. Essentially, it blocks the parasympathetic nervous system's effects on these receptors, leading to decreased secretions and other effects. Regarding administration, the typical adult dose administered intravenously or intramuscularly ranges from 0.2 to 0.4 milligrams. For children, the dose is calculated based on weight, usually between 4 and 10 micrograms per kilogram. After IV injection, you'll see the peak effect in about 3 minutes, so it acts quite rapidly. Now, let's consider the effects, starting with the cardiovascular system. Interestingly, at normal doses, glycopyrronium has minimal impact on blood pressure and causes fewer dysrhythmias compared to atropine. However, if given intravenously in doses over 0.2 milligrams to anesthetized patients, it can cause tachycardia. Importantly, it's protective against bradycardias, which can be quite beneficial during surgery. The vagolytic effects, or the ability to block vagus nerve activity, tend to last around 2 to 3 hours. Finally, on the respiratory system, this drug has a significant and long-lasting bronchodilator effect, which can be very useful in managing airway constriction. It also causes an increase in physiological dead space, meaning some areas of the lung are ventilated but not perfused, which is an important consideration during respiratory management. So, in summary, glycopyrronium bromide is a powerful anticholinergic agent with specific uses in clinical practice, especially for controlling secretions and bronchodilation, with predictable cardiovascular effects. Let's start with the central nervous system effects. Glycopyrronium bromide can cross the blood-brain barrier, but interestingly, it tends to cause fewer central effects like headache or drowsiness compared to other agents. Also, when it comes to recovery from anesthesia, patients tend to recover more quickly with glycopyrronium than with atropine. And importantly, unlike some anticholinergic drugs, it doesn't affect pupil size or accommodation, which can be quite relevant during eye procedures or assessments. Moving on to its actions on secretions, glycopyrronium has a very potent antisialogog effect. It can last around 8 hours after injection, whether given intravenously or intramuscularly. In fact, it's about 5 times more potent than atropine in reducing saliva production. It also significantly decreases gastric volume by about 90% for roughly 4 hours after administration and reduces antral motility, which can be helpful during certain surgeries. Additionally, it reduces the tone of the lower esophageal sphincter. This is an important point because it can influence reflux risk, especially in vulnerable patients. Now, regarding metabolic and other systemic effects, Glycopyrronium inhibits sweat gland activity, but surprisingly, this doesn't significantly affect body temperature. So, while it reduces sweating, it doesn't usually cause hyperthermia or hypothermia under normal circumstances. Let's talk about side effects and toxicity. Since it's an anticholinergic, it can produce typical side effects like dry mouth, difficulty urinating, and decreased sweating. These are important to monitor, especially in susceptible patients. Considering pharmacokinetics, oral absorption of glycopyrronium is quite poor, with only about 5% bioavailability. However, when given via intramuscular or intravenous routes, absorption is much more efficient and comparable. The drug redistributes rapidly. About 90% disappears from plasma within 5 minutes, which is quite quick. Another key point is that glycopyrronium can cross the placenta, so it has the potential to cause fetal tachycardia, which must be considered during pregnancy or labor. In terms of metabolism, in animals, it undergoes hydroxylation and oxidation in the liver, but in humans, very little biotransformation occurs. Most of the drug is excreted unchanged, around 80% in urine and 15% in bile. Its clearance rate is approximately 0.89 liters per minute, and the half-life ranges from about 0.6 to 1.1 hours. To sum up, glycopyrronium bromide's pharmacokinetics and effects make it a useful agent, especially when rapid recovery from anesthesia and minimal central effects are desired. Let's take a closer look at atropine sulfate. It has several important uses in clinical practice. First, it's used to dry secretions before administering anesthesia with ether or chloroform, helping to keep the airway clear. It also plays a crucial role in treating bradycardia caused by increased vagal tone, effectively increasing the heart rate. Additionally, atropine can counteract the muscarinic effects of certain anticholinergic agents, balancing the parasympathetic activity. During cardiopulmonary resuscitation, atropine is used to help restore heart rhythm by blocking excessive vagal stimulation. It's also a key treatment in organophosphorus poisoning, where it helps counteract the excessive cholinergic effects caused by nerve agents or pesticides. Now, regarding its chemical nature, atropine is an alkaloid derived from the plant Atropa belladonna. Structurally, it's a tertiary amine formed as an ester of tropic acid and tropine. In terms of presentation, atropine usually comes as a clear, colorless solution for injection, with concentrations of 0.5 or 0.6 mg per ml, and in 3 mg vials in a 10 ml volume. It's also available as tablets, typically 0.6 mg. The main action of atropine is as an anticholinergic agent, meaning it blocks the effects of acetylcholine. Its mode of action is through competitive antagonism at muscarinic receptors, which explains its effects on slowing secretions and increasing heart rate. It has minimal effects on nicotinic receptors unless used at very high doses. As for administration, atropine can be given either intramuscularly or intravenously, usually at doses of 0.015 to 0.02 mg per kilogram for children. In adults, the oral dose ranges from 0.2 to 0.6 mg, with a total of about 3 mg needed to achieve complete vagal blockade. So, understanding these points helps us appreciate how atropine fits into emergency and perioperative care, as well as its role in managing poisoning cases. Let's now look at the effects of atropine across different systems, starting with the cardiovascular system, CVS. In low doses, atropine can initially cause a slowing of the heart rate, known as bradycardia, but then it typically leads to an increase in heart rate or tachycardia, which is its usual effect. It increases cardiac output, meaning the amount of blood the heart pumps per minute goes up. Interestingly, it has little impact on blood pressure itself. Atropine also decreases the time it takes for electrical signals to pass through the atrioventricular node, which can sometimes lead to irregular heart rhythms or dysrhythmias. And at higher doses, you might observe dilation of facial capillaries, leading to flushing or redness in the face. Moving on to the respiratory system, atropine causes bronchodilation, helping to open up the airways. This also increases the amount of dead space in the lungs, which is the area where no gas exchange occurs. It reduces bronchial secretions, making it useful in certain respiratory conditions. As a result, the respiratory rate tends to increase, and there's also a reported decrease in laryngospasm, which is a protective reflex that can sometimes cause airway obstruction. Now on to the central nervous system effects. Atropine can either excite or depress the CNS, leading to a condition called central anticholinergic syndrome. This syndrome includes symptoms like drowsiness or somnolence, confusion, memory loss, agitation, hallucinations, speech difficulties, unsteady movements, and even delirium. It's important to recognize these effects as they can vary from person to person. Additionally, atropine has some beneficial actions, such as acting as an antiemetic to prevent nausea and vomiting, and it also has anti-Parkinsonian properties. Finally, in the autonomic system, atropine reduces saliva production, which is why it's sometimes used to manage excessive salivation. It also decreases gastric secretions and reduces the tone and movement of the gastrointestinal tract, slowing down peristalsis. On the biliary side, it has a mild antispasmodic effect, helping to relax the biliary ducts. Furthermore, it lowers the tone of the lower esophageal sphincter, which can have implications for conditions like reflux. So overall, atropine's effects are widespread, influencing many systems in ways that are important to consider when using the drug clinically. On this slide, we're looking at some of the physiological effects of atropine on the urinary tract. As you can see, it decreases tone and peristalsis, which means it slows down the movement of urine through the urinary system. This is important because it can lead to urinary retention, especially in susceptible individuals. Moving on to other systemic effects, atropine can cause cycloplegia and mydriasis, which are paralysis of the ciliary muscle and dilation of the pupil, respectively. These effects are useful in ophthalmology, but also raise intraocular pressure, which we need to watch out for in patients with glaucoma. It also inhibits sweating, which can lead to an increase in basal metabolic rate. Interestingly, atropine suppresses ADH secretion, affecting water balance and potentially leading to dehydration if not monitored. Now, regarding toxicity and side effects, intramuscular injections can be painful, and many patients find the dry mouth sensation quite unpleasant. In elderly patients, we might see a central anticholinergic syndrome, which involves confusion or hallucinations, while in children, inhibition of sweating could cause hyperpyrexia or dangerously high fever. And of course, urinary retention can be precipitated by atropine, which is a significant clinical consideration. Let's briefly review the pharmacokinetics. Atropine is rapidly absorbed from the gut, but its oral bioavailability is relatively low, around 10 to 25%. It binds about half to plasma proteins, and its volume of distribution ranges from 2 to 4 liters per kilogram, meaning it distributes fairly widely in the body. It crosses the placenta and blood-brain barrier, which explains some of its central effects. Metabolically, it's hydrolyzed in the liver and tissues into tropine and tropic acid. Most of the drug, about 94%, is excreted in the urine within 24 hours, some unchanged. The clearance rate is about 70 liters per hour, and its half-life is roughly 2.5 hours. Understanding these pharmacokinetics helps us appreciate how atropine acts and how to manage its dosing and potential side effects effectively. Let's talk about antacids, which are commonly used to relieve heartburn and indigestion. They work by reducing the amount of acid in the stomach, providing quick relief. Some of the drugs in this category include pantoprazole, omeprazole, and ranitidine. Focusing on pantoprazole, this medication belongs to the proton pump inhibitor group, or PPI. Its main action is to provide a long-lasting reduction of gastric acid production, which makes it very effective for treating conditions caused by excess stomach acid. Pantoprazole is used for several purposes. It helps reduce the acid content in the stomach, which can alleviate symptoms and promote healing of ulcers. It's also used to treat esophagitis and GERD, gastroesophageal reflux disease, by decreasing acid reflux. Additionally, it plays a crucial role in eradicating Helicobacter pylori, the germ responsible for many ulcers. It's also helpful in preventing ulcers caused by NSAIDs, and it's used in managing Zollinger-Ellison syndrome, a condition characterized by excessive stomach acid production. Chemically, pantoprazole is part of the benzimidazole class, which is important to note because it influences how the drug works. In terms of presentation, pantoprazole is available as a colorless powder, typically in a 40 mg dose. For intravenous use, it needs to be diluted with distilled water. It also comes in oral enteric-coated tablets of 40 mg to protect the drug from stomach acid and ensure it reaches the intestine where it can be absorbed. The main action of pantoprazole targets the proton pumps. These are the final step in acid secretion in the stomach. By inhibiting these pumps, it effectively reduces acid production. Its mode of action involves binding to the proton pumps in the stomach lining, which blocks acid secretion at its source. This makes it a powerful and sustained way to control excess stomach acid, helping manage various acid-related conditions. Now, let's look at how pantoprazole works once it enters the gastric parietal cells. It gets converted into its active form, which is a sulfonamide. This active metabolite is crucial because it interacts directly with the proton pump. The sulfonamide binds specifically to the proton pump at the thiol group, effectively inhibiting its function. This binding prevents the proton pump from passing protons into the gastric lumen, which means that the formation of hydrochloric acid, or HCl, is significantly inhibited in the stomach environment. Regarding administration, pantoprazole can be given either intravenously or orally. For adults, the typical dose is around 40 milligrams. This flexibility in routes of administration makes it a versatile option for managing acid-related conditions effectively. Now, let's take a closer look at some of the potential effects associated with PPI use. First, cardiovascular risks are a concern. Prolonged or high-dose PPI therapy has been linked to an increased risk of acute myocardial infarction or stroke. Additionally, there's the risk of malignant ventricular arrhythmias, which can develop due to hypermagnesemia. This condition lengthens the QT interval on the ECG and can lead to torsade de pointe, a serious arrhythmia. We also see that PPIs can impair the antiplatelet effect of clopidogrel, which is important to remember for patients on antiplatelet therapy. Furthermore, PPIs can increase blood levels of chromogranin A, a marker that can be associated with certain neuroendocrine tumors. Switching gears to respiratory effects, pneumonia is notably more common with PPI use, even in short-term therapy lasting 30 to 90 days. Moving on to neurological effects, some patients report headaches, dizziness, or vertigo. Less commonly, we may see depression, disturbed sleep, insomnia, drowsiness, nervousness, and even more severe issues like hallucinations or delirium. There's also some emerging evidence suggesting a possible link between PPI use and Alzheimer's disease. In the gastrointestinal system, PPI use increases the risk of both incidental and recurrent Clostridium difficile infections, as well as other enteric infections such as non-typhoid Salmonella and Campylobacter. Regarding the genitourinary system, PPIs can cause acute interstitial nephritis, which is an inflammatory condition of the kidneys. Excessive use may lead to chronic kidney disease, and in patients already diagnosed with CKD, PPI therapy might accelerate disease progression. Other notable effects include deficiencies in vitamin B12, iron, and calcium, which can have broader impacts on health. There are also concerns about hepatic encephalopathy, peritonitis, liver carcinoma, as well as increased risk of fractures, osteoporosis, and myopathy. In summary, while PPIs are highly effective for acid-related disorders, it's crucial to be aware of these potential effects. They highlight the importance of careful patient selection, appropriate dosing, and monitoring during therapy to minimize risks. Now let's look at some potential side effects of omeprazole. Commonly, patients may experience headache, rash, dizziness, and gastrointestinal symptoms. These gastrointestinal issues include nausea, vomiting, abdominal pain, constipation, and diarrhea. It's important to be aware of these, but they are generally manageable. Moving on to the pharmacokinetics, or how the drug moves through the body. Omeprazole is rapidly absorbed when taken orally or through intravenous administration. You'll see the onset of action typically within 2 to 4 hours, and it lasts about 24 hours, which supports once daily dosing in most cases. The bioavailability is approximately 77%, and interestingly, neither food nor antacids significantly affect how much of the drug gets absorbed. Regarding distribution, about 98% of the drug binds to plasma proteins, and the volume of distribution ranges from 11 to 24 liters. When it comes to metabolism, omeprazole is processed mainly in the liver via a pathway called demethylation, involving the CYP-C19 enzyme. This is then followed by sulfation. As for excretion, roughly 71% of the dose is eliminated through urine, while about 18% is excreted via feces through biliary pathways. The drug has a half-life of around 1 hour, and its clearance rate ranges from 7.6 to 14 liters per hour. Now, let's briefly touch on the uses of omeprazole. It's primarily used in treating peptic ulcer disease, which involves ulcers in the stomach or duodenum. It's also effective for peptic esophagitis, which is inflammation of the esophagus due to acid reflux. Additionally, it's used in managing Zollinger-Ellison syndrome, a condition characterized by excessive gastric acid production. Preventing NSAID-associated ulcers is another key use, especially for patients who need long-term NSAID therapy. Lastly, it's often employed following endoscopic procedures to treat bleeding caused by peptic ulcers. Chemically, omeprazole is classified as a benzimidazole derivative, which helps explain its mechanism of action. In terms of presentation, it comes as capsules with doses of 10, 20, or 40 milligrams, and there are also 40 milligram vials containing the sodium salt form, used particularly for intravenous administration. Overall, understanding these key points about side effects, pharmacokinetics, and clinical uses helps us appreciate how omeprazole functions as a cornerstone in managing acid-related disorders. Let's take a closer look at how omeprazole works to inhibit gastric acid secretion. Its main action is to block both basal and stimulated acid production in the stomach. It does this by forming a derivative that binds irreversibly to the proton pumps in the parietal cells. This binding non-competitively inhibits the pump's activity, which is crucial because the proton pump is the final pathway for hydrogen ion secretion into the stomach. Essentially, by shutting down this pump, omeprazole effectively reduces acid output. Now, regarding administration in adults, the typical oral dose for peptic ulcer disease is between 20 to 40 milligrams daily, usually for 4 to 8 weeks. For conditions like Zollinger-Ellison syndrome, which involves excessive acid production, doses can go up to 120 milligrams per day. When given intravenously, it's administered over 5 minutes, ensuring quick and controlled delivery. Let's talk about the effects. Omeprazole significantly decreases the volume of gastric juice, which is beneficial in ulcers and acid-related conditions. Interestingly, it doesn't affect how quickly the stomach empties. A single 20 milligram dose can keep acid secretion low for a full 24 hours, making it quite effective for daily management. From a metabolic perspective, omeprazole doesn't seem to impact endocrine functions, which is reassuring in terms of systemic effects. Regarding safety, it's generally well tolerated. Common side effects can include rashes, nausea, headaches, and gastrointestinal disturbances. Sometimes liver function might be affected, and rarely arrhythmias can occur. Finally, on pharmacokinetics, omeprazole is rapidly absorbed after ingestion, with bioavailability ranging from 40 to 97% depending on the formulation and dose. Interestingly, it can increase its own bioavailability because it degrades under acidic conditions, so the less acid in the stomach, the more effective it becomes. This self-enhancing aspect helps maintain its efficacy over time. Overall, understanding these mechanisms and pharmacokinetics helps us appreciate why omeprazole is such a valuable tool in managing acid-related diseases. Let's take a closer look at the distribution, metabolism, and excretion of this drug. It is highly protein-bound in the plasma, with about 95 to 96% binding, mainly to albumin and alpha-1 acid glycoprotein. This means most of the drug circulates bound to proteins, which can influence its activity and distribution. The volume of distribution, or VD, is relatively small, around 0.3 to 0.4 liters per kilogram, indicating it mostly stays within the plasma and extracellular fluid. Moving on to metabolism, the drug is quickly and completely metabolized. It undergoes oxidation to form a sulfone, reduction to a sulfide, and hydroxylation. These metabolic pathways help in preparing the drug for elimination from the body. Regarding excretion, about 80% of an oral dose is eliminated via the urine, while the remaining portion exits through the feces. The clearance rate, which measures how efficiently the body removes the drug, ranges between 533 and 666 milliliters per minute. The half-life, or the time it takes for the plasma concentration to reduce by half, is quite short, between 0.5 and 1.5 hours. Now, shifting focus to ranitidine, which is used primarily to treat conditions involving excess stomach acid. It's indicated for peptic ulcer disease, reflux esophagitis, Zollinger-Ellison syndrome, and also for preventing stress ulcers in critically ill patients. Additionally, it's helpful before general anesthesia, especially in pregnant women or during labor, to reduce the risk of acid aspiration. Chemically, ranitidine is a furan derivative, which plays a role in its mechanism of action. It's available in various forms, like a clear solution for injections, tablets, and syrup, making it versatile for different clinical needs. The main action of ranitidine is to inhibit gastric acid secretion. It does this by competitively blocking histamine H2 receptors on the parietal cells in the stomach lining. Since histamine enhances the effects of gastrin and acetylcholine in stimulating acid production, blocking these receptors effectively reduces acid secretion. So, by preventing histamine from binding, ranitidine helps manage conditions caused by excessive stomach acid, tying back into our overall discussion on drug mechanisms and therapeutic uses. Now, let's look at the routes of administration and dosing for ranitidine. It can be given either by slow intravenous or intramuscular injection, typically at a dose of 50 milligrams every 6 to 8 hours. Alternatively, the oral dose is usually 150 milligrams twice daily, making it flexible depending on the clinical situation. Moving on to the effects, starting with the cardiovascular system, at normal doses, ranitidine doesn't have any significant effect on the CVS. Similarly, it doesn't impact respiratory parameters, so it's quite safe in that regard. The main action of ranitidine is on the gastrointestinal system. It profoundly inhibits gastric acid secretion. This results in a reduction in the volume of acid, as well as decreases in hydrogen ion and pepsin content, which is crucial in managing acid-related conditions. Interestingly, ranitidine's duration of antisecretory activity is longer than that of cimetidine, making it more effective in certain cases. When we consider metabolic and other effects, ranitidine doesn't exhibit antiandrogenic or antidopaminergic effects, and importantly, it doesn't interfere with cytochrome P450 enzymes, unlike cimetidine. It does cross the placenta, but reassuringly, no adverse effects on fetal well-being have been demonstrated so far. Regarding toxicity and side effects, some reversible issues have been reported, such as liver function test abnormalities, rashes, and even anaphylactoid reactions. Rarely, patients may experience reversible confusion, thrombocytopenia, or leukopenia after taking ranitidine. Finally, let's touch on its pharmacokinetics. Ranitidine has an oral bioavailability of about 50 to 60%, which means roughly half of the oral dose reaches systemic circulation. In the blood, about 15% of the drug is bound to plasma proteins, and the volume of distribution is around 1.2 to 1.8 liters per kilogram. A small part of the drug is metabolized through oxidation and methylation pathways, which helps with its clearance. All these pharmacokinetic and pharmacodynamic features make ranitidine a reliable and effective option for managing gastric acid-related conditions with a good safety profile. Let's talk about excretion first. Ranitidine is primarily excreted unchanged by the kidney. Its clearance rate is about 10 milliliters per minute per kilogram, and its elimination half-life ranges from roughly 1.6 to 2.5 hours. This means that the drug is mostly cleared through renal pathways, which is important when considering dosage adjustments in patients with kidney issues. Moving on to prokinetics and antiemetics, these are two classes of drugs that help manage gastrointestinal motility and nausea. Prokinetics, as the name suggests, promote the movement of ingested material through the gastrointestinal tract, which can be helpful in conditions like gastroparesis or reflux. Antiemetics, on the other hand, are used to prevent or treat nausea and vomiting caused by various factors, including medications, radiotherapy, or gastrointestinal disorders. Some common drugs in these categories include metoclopramide, ondansetron, and domperidone. Focusing on metoclopramide, it's a versatile drug used in several clinical situations. It helps treat digestive disorders such as hiatus hernia, reflux esophagitis, and gastritis. It's also effective against nausea and vomiting caused by drugs, radiotherapy, or hepatic and biliary disorders. Additionally, it's used in diagnostic radiology of the gastrointestinal tract, in managing migraines, and postoperatively for gastric hypotonus. Chemically, metoclopramide is a chlorinated derivative of prokinamide, which influences its mechanism of action. In terms of presentation, you can find metoclopramide as 10 mg tablets, a syrup with 1 mg per milliliter, and as a clear, colorless injection solution containing 5 mg per milliliter of the hydrochloride form. The main actions of metoclopramide are twofold. It increases gastrointestinal motility and acts as an antiemetic. This dual functionality makes it particularly useful in managing a variety of gastrointestinal and neurological conditions linked to nausea and motility issues. Let's talk about the mode of action of metoclopramide. The effects it has on gastrointestinal motility are mainly mediated through three key mechanisms. First, it acts as an antagonist of peripheral dopaminergic D2 receptors, which helps to enhance GI motility. Second, it boosts peripheral cholinergic responses, further promoting movement within the gut. And third, it has a direct effect on smooth muscle, increasing its tone to support effective motility. Now, regarding its antiemetic effects, these are primarily due to central mechanisms. The drug blocks dopamine D2 receptors in the brain, which raises the threshold for triggering vomiting at the chemoreceptor trigger zone. Additionally, it decreases the sensitivity of visceral nerves that send afferent signals to the vomiting center, making nausea and vomiting less likely. When it comes to routes of administration, metoclopramide can be given orally, intravenously, or intramuscularly. The standard adult dose across these routes is 10 milligrams every 8 hours. For nausea and vomiting, a dose of 1 to 2 milligrams per kilogram is often recommended. Let's look at some of the effects. In the cardiovascular system, there have been occasional reports of hypotension during anesthesia, as well as rare cases of cardiac arrest, dysrhythmias, and hypertension, particularly in patients with pheochromocytoma. On the central nervous system, metoclopramide raises the vomiting threshold and can prevent apomorphine-induced vomiting, thanks to its neuroleptic, dopamine-blocking properties. In the gastrointestinal system, it increases the tone of the lower esophageal sphincter by about 17 mmHg, which helps reduce reflux. It also accelerates gastric emptying and enhances gastric contractions, although its effects on large bowel motility can vary. Importantly, it does not affect gastric secretion. Finally, in the genitourinary system, metoclopramide may increase ureteric peristaltic activity, which could be relevant in certain clinical situations. Overall, understanding these mechanisms helps us appreciate how metoclopramide is a versatile agent in managing GI motility and nausea. Let's take a closer look at the metabolic and other effects of this drug. It stimulates prolactin release, which can have hormonal effects, and it also causes a transient increase in aldosterone secretion, impacting fluid and electrolyte balance. Now, regarding toxicity and side effects, about 11% of patients experience adverse reactions when taking this medication. The most common issues include drowsiness, dizziness, faintness, and bowel disturbances. It's important to be aware of these to monitor patients effectively. Additionally, although rare neuroleptic malignant syndrome has been reported, which highlights the need for caution. Moving on to pharmacokinetics, absorption is quite rapid after oral administration, but the bioavailability varies widely, from about 32% to 97%. This variability mainly results from first-pass conjugation in the liver, where the drug is metabolized to sulfate. In terms of distribution, the drug is 13 to 22% protein-bound in plasma, and the volume of distribution ranges from 2.2 to 3.4 liters per kilogram. It primarily undergoes metabolism in the liver, with the main metabolite being a sulfate derivative. Excretion-wise, roughly 80% of an oral dose is eliminated in the urine within 24 hours. Of that, 20% is unchanged drug, while the rest is a sulfated metabolite. The clearance rate ranges from 8.8 to 11.6 milliliters per minute per kilogram, and the elimination half-life is between 2.6 and 5 hours. Now, shifting focus to ondansetron, which we'll discuss next. It's mainly used for managing nausea and vomiting caused by chemotherapy and radiotherapy, and it's also effective in preventing postoperative nausea and vomiting. Chemically, it's a synthetic carbazole, and it's available in various forms, like a clear, colorless solution in ampules, as tablets, and as suppositories. Understanding these pharmacokinetic and clinical details helps us optimize the use of these drugs and anticipate potential side effects, which ultimately improves patient care. Let's take a closer look at the main action of this drug, which is as an antiemetic. It works by being a highly selective antagonist at 5-HT3 receptors, and it acts both centrally in the brain and peripherally in the gut. Emetogenic stimuli, such as chemotherapy or radiotherapy, cause the release of serotonin, or 5-HT, in the small intestine. This triggers a vomiting reflex by activating vagal afferents through those 5-HT3 receptors. Ondansetron works by blocking this process, preventing the initiation of that reflex. Additionally, activation of vagal afferents can lead to the release of 5-HT in the area postrema, which is a part of the brain involved in vomiting. This means ondansetron can help prevent vomiting triggered by this pathway as well. Now, regarding how it's administered, for preventing chemo or radiotherapy-induced nausea and vomiting, the dose can be flexible, typically ranging from 8 to 32 milligrams per day. For prophylaxis against postoperative nausea and vomiting, a single dose of 4 milligrams given either intramuscularly or slowly, intravenously, is common. In children, the dose is generally 0.1 milligrams per kilogram. Moving on to effects, ondansetron doesn't seem to have significant cardiovascular effects, so it's considered safe in that regard. It also doesn't affect how we respond to carbon dioxide in terms of ventilation, and importantly, it doesn't cause sedation or impair psychomotor performance. It doesn't affect gastric motility, but does increase the transit time of the large bowel, which is an interesting point. Also, it has no impact on serum prolactin levels or blood clotting functions. As for side effects, some common ones include constipation, headaches, and flushing. There's a potential for bradycardia, especially if given rapidly through IV, so monitoring during administration is advisable. Overall, it's a well-tolerated medication, but like all drugs, it's important to be aware of these possible side effects. Let's take a closer look at the kinetics of domperidone. When taken orally, it is passively and completely absorbed in the gastrointestinal tract, but it does undergo first-pass metabolism in the liver. This means that only about 60 to 65% of the drug reaches systemic circulation in its active form. Once in the bloodstream, the drug binds quite extensively to plasma proteins, around 70 to 76%, so a significant portion is bound, which influences its distribution. Speaking of distribution, the volume of distribution is approximately 2 liters per kilogram, indicating how the drug disperses throughout body tissues. Moving on to metabolism, domperidone is extensively processed in the liver. It undergoes hydroxylation, a key step mediated by multiple hepatic cytochrome P450 enzymes. This extensive hepatic metabolism helps in clearing the drug from the body. As for excretion, less than 5% of the unchanged drug is excreted in the urine, showing that most of it is metabolized before elimination. The clearance rate is about 6.3 milliliters per kilogram per minute, and the drug has an elimination half-life of around 3 hours, which informs us about how frequently dosing might be needed. Now, focusing on the clinical aspect, domperidone is primarily used to treat symptoms like nausea and vomiting, regardless of the cause. It's a butyraphanon derivative, which is important because it influences its pharmacological properties. In terms of presentation, you can find domperidone as tablets containing 10 milligrams, a suspension with 1 milligram per milliliter, and even suppositories with 30 milligrams. Its main action is to increase gastrointestinal motility and tone, which helps alleviate symptoms like nausea. Plus, it has a central antiemetic effect, meaning it acts in the brain to reduce the sensation of nausea. The mode of action involves antagonizing peripheral dopamine D2 receptors in the gastrointestinal tract, which enhances motility and reduces nausea signals. Regarding administration, the typical adult oral dose ranges from 10 to 20 milligrams, taken 4 to 8 hours apart. For rectal administration, a single dose of 60 milligrams is used, also spaced out similarly. Connecting all these points, understanding the pharmacokinetics and mode of action of domperidone helps us optimize its use for patients experiencing nausea and vomiting, ensuring effective and safe treatment. Let's go over the effects of domperidone. First, regarding the cardiovascular system, it doesn't have significant effects on cardiac output, heart rate, blood pressure, or conduction. So, from a heart standpoint, it's relatively safe in that regard. Moving to the central nervous system, it doesn't easily cross the blood-brain barrier, which means it largely avoids central nervous system side effects. Now, in terms of the gastrointestinal system, domperidone increases the tone of the lower esophageal sphincter and accelerates gastric emptying. This makes it useful for conditions like reflux and gastroparesis. Interestingly, it has an antiemetic effect similar to metoclopramide, especially in preventing postoperative vomiting, but it seems to be more effective when treating established postoperative vomiting. Another important point is that domperidone can increase serum prolactin levels, which may lead to some side effects related to that. Speaking of side effects, generally, it's well tolerated, but galactorrhea and gynecomastia have been reported in some cases. Let's talk about its pharmacokinetics now. When taken orally, the bioavailability is only about 13 to 17%. That's because of first-pass metabolism in the gut wall and the liver, which reduces how much active drug actually enters circulation. In the plasma, about 92% of domperidone binds to proteins, and its volume of distribution is around 5.7 liters per kilogram. Most of the drug, about 90%, is metabolized through hydroxylation and oxidative N-dealkylation pathways. Excretion-wise, approximately 30% of the drug is eliminated via urine and around 60% through feces. The half-life of domperidone is approximately 7.5 hours, which informs dosing intervals. Importantly, in patients with renal impairment, the drug doesn't tend to accumulate significantly. However, it's crucial to remember that there have been reports of cardiac arrest associated with domperidone use, so caution is always advised, especially in vulnerable populations. Sedatives, hypnotics, and tranquilizers are drugs that produce drowsiness and help initiate and maintain sleep. They are commonly used to treat conditions like anxiety, sleep disorders, and seizures. In this category, one key drug is midazolam. Midazolam is quite versatile and is used in various clinical settings. For example, it's used for the induction of anesthesia, helping to quickly put a patient under safely. It's also utilized for sedation during procedures like endoscopies or surgeries performed under local anesthesia, especially in intensive care units. Additionally, midazolam serves as a hypnotic to help with sleep issues and is often given as premedication before general anesthesia to calm patients beforehand. Interestingly, it is also used in managing chronic pain in some cases. Chemical-wise, midazolam is a water-soluble imidazobenzodiazepine, which means it dissolves well in water and belongs to the benzodiazepine family. In terms of presentation, it usually comes as a clear, colorless solution of midazolam hydrochloride, available in strengths of 1, 2, or 5 milligrams per milliliter. Now, regarding its main actions, the primary effect we focus on is hypnosis, meaning it induces sleep or sedation efficiently. This makes midazolam particularly useful in medical procedures where quick onset of sedation is necessary. Let's take a look at the various effects and mechanisms of benzodiazepines. They are commonly used for sedation, anxiolysis, anterograde amnesia, anticonvulsant effects, and muscular relaxation. In terms of their mode of action, benzodiazepines work by targeting specific receptors in the central nervous system. These receptors are found throughout the brain, especially in the cortex and midbrain. They are closely linked with GABA receptors, which are the primary inhibitory receptors in the brain. When benzodiazepines activate these receptors, they facilitate GABA's activity, leading to opening of chloride ion channels. This causes hyperpolarization of the neuron, making it less likely to fire and thus producing their calming effects. Regarding administration, for premedication, intramuscular doses are typically around 0.07 to 0.08 milligrams per kilogram. For sedation, intravenous doses range from 0.07 to 0.1 milligrams per kilogram, carefully titrated based on the patient's response. The goal is to reach a level of drowsiness and slurring of speech, but importantly, the patient should still respond to commands. Now, let's discuss some of the physiological effects. On the cardiovascular side, benzodiazepines tend to decrease systolic blood pressure by about 5% and diastolic pressure by around 10%. They also reduce systemic vascular resistance significantly, between 15 and 33%, while the heart rate tends to increase by approximately 18%. In terms of respiration, these drugs lower tidal volume, but this is usually offset by an increased respiratory rate, so the overall minute ventilation remains fairly stable. However, it's important to note that apnea, or temporary cessation of breathing, occurs in a notable percentage of patients, anywhere from 10 to 77%, especially when midazolam is used as an induction agent. So, understanding these effects helps us balance the therapeutic benefits with potential risks, especially in settings requiring precise control of sedation and airway management. Let's start with the effects of CNS. Midazolam produces hypnosis, sedation, and notably anterograde amnesia, which means it helps prevent memory formation after administration. It also causes a dose-related decrease in cerebral oxygen consumption and blood flow, indicating that higher doses can significantly reduce brain activity and perfusion. Moving to the anesthesia context, combining midazolam with fentanyl during induction tends to lower the incidence of postoperative vomiting, which is a beneficial side effect for patient comfort. However, it's important to note that this drug can reduce hepatic blood flow, so liver function and drug metabolism may be impacted. In terms of renal effects, midazolam decreases renal blood flow, which could be relevant in patients with pre-existing kidney issues. On the metabolic side, midazolam suppresses the adrenergic response to stress. That's part of how it calms the nervous system, while cortisol and renin responses are unaffected. It also significantly inhibits phagocytosis and the bactericidal activity of leukocytes, which could influence immune responses. Regarding toxicity and side effects, most are mild. Sometimes patients experience discomfort at the injection site. In children, especially after prolonged infusions, withdrawal phenomena might occur, so careful monitoring is necessary. Now, let's look at the pharmacokinetics. When taken orally, midazolam has about 44% bioavailability, but if administered intramuscularly, it jumps to 80–100%. It's highly protein-bound in plasma, about 96%, and the volume of distribution ranges from 0.8 to 1.5 liters per kilogram, although this can increase up to 3.1 liters per kilogram in critically ill patients. Metabolically, midazolam is fully processed in the liver. It's converted into hydroxylated derivatives, which are then conjugated to glucuronides. These metabolites still bind to benzodiazepine receptors in the CNS and are pharmacologically active, contributing to its effects. Excretion mainly occurs through the urine, predominantly as these hydroxylated derivatives. Renal impairment has little impact on clearance because of this. Its clearance rate is between 5.8 and 9 milliliters per minute per kilogram, with an elimination half-life generally around 1.5 to 3.5 hours. However, in critically ill patients, this half-life can extend up to approximately 5.4 hours, which is important to consider in dosing and duration of sedation. Diazepam is a versatile medication with several important uses. It's commonly used for short-term treatment of anxiety, helping to calm nerves and reduce stress quickly. It's also a key drug in managing status epilepticus, which is a severe and ongoing seizure that needs prompt control. Additionally, it's effective in relieving muscle spasms caused by conditions like tetanus or other spastic disorders. Another significant use is during alcohol withdrawal, where it helps to prevent seizures and manage withdrawal symptoms. Diazepam is also used as a premedication before certain procedures to ease anxiety and make the experience more comfortable. Plus, it's often administered to provide sedation during endoscopy or other procedures performed under local anesthesia, helping patients relax and remain comfortable. Chemically, diazepam is classified as a benzodiazepine, which is important because of its specific mechanism of action on the brain to produce calming effects. In terms of presentation, diazepam comes in various forms: tablets of 2, 5, or 10 mg, syrups with concentrations like 0.4 or 1 mg/ml, suppositories of 10 mg, and rectal solutions containing 2 or 4 mg/ml. There are also injectable forms, including a clear yellow solution and a white oil-in-water emulsion, both containing 5 mg/ml. Now let's look at its main actions. Diazepam has a broad range of effects. It induces hypnosis, meaning it helps with sleep. It provides sedation, helping calm agitation, and it has strong anxiolytic properties to reduce anxiety. It also causes anterograde amnesia, which can be useful during procedures to prevent memory of unpleasant experiences. Its anticonvulsant effect is crucial in controlling seizures, and it also promotes muscular relaxation, making it effective for muscle spasms and spastic conditions. These combined effects make diazepam a key medication in both emergency and routine settings, highlighting its importance within the broader scope of sedatives and anticonvulsants. Let's take a closer look at how benzodiazepines work. They act on specific receptors called benzodiazepine receptors, which are scattered throughout the central nervous system. These receptors are especially concentrated in the cortex and midbrain, regions crucial for cognition and emotion. Interestingly, these receptors are closely linked with GABA receptors, and their activation actually facilitates GABA's activity. When GABA receptors are activated, they open chloride ion channels, which then either hyperpolarize the neuron or short-circuit the synaptic membrane, reducing neuronal excitability. This process explains many of the calming effects of benzodiazepines. Now, moving on to how these drugs are administered and dosed. For adults, the oral dose typically ranges from 2 to 60 milligrams per day, divided into smaller doses throughout the day. When given intravenously, the initial dose is usually between 10 and 20 milligrams, but this can be increased depending on the clinical response. Let's discuss the effects these drugs have on different systems. Starting with the cardiovascular system, or CVS. Intravenous diazepam can cause a slight decrease in blood pressure and cardiac output. Interestingly, It also increases coronary blood flow because of coronary arterial vasodilation, which can help improve oxygen delivery to the heart muscle and decrease myocardial oxygen consumption. In the respiratory system, or RS, large doses of benzodiazepines can lead to respiratory depression, which is an important side effect to watch out for. Moving to the central nervous system, or CNS, diazepam has several notable effects. It's primarily anxiolytic, so it reduces anxiety and can decrease aggression. However, sometimes paradoxical excitement can occur instead. It also causes sedation, hypnosis, and anterograde amnesia, meaning it can impair the formation of new memories after administration. Additionally, diazepam has anticonvulsant and analgesic properties, making it useful in managing seizures and some types of pain. Of course, like all medications, benzodiazepines can have side effects. CNS depression is common, leading to drowsiness, ataxia, and headaches. Some patients might experience rashes, gastrointestinal upset, or urinary retention. It's also important to note that with prolonged use, tolerance and dependence can develop, which can pose challenges when stopping the medication. Abrupt withdrawal after long-term use can lead to withdrawal symptoms, so careful management is essential. Overall, while benzodiazepines are powerful and versatile medications, understanding their mechanisms, effects, and potential side effects is key to using them safely and effectively. Now, it's important to note that benzodiazepines like diazepam may produce side effects such as insomnia, anxiety, confusion, and in some cases, psychosis. When administering diazepam intravenously, keep in mind that the oil and water preparation tends to be less irritating to the veins compared to other formulations. Let's talk about the pharmacokinetics of diazepam. After oral administration, it is rapidly absorbed, with a bioavailability ranging from 86 to 100%. This means most of the drug reaches systemic circulation efficiently. However, when given intramuscularly, the absorption is slower, which is an important consideration for dosing. In terms of distribution, diazepam binds very tightly to plasma proteins, about 99%, and has a volume of distribution between 0.8 and 1.4 liters per kilogram. This extensive binding influences its onset and duration of action. Moving on to metabolism, diazepam is processed in the liver, converting into active metabolites. The main one is desmethyldiazepam, which has a notably long half-life of around 100 hours. Other active metabolites include oxazepam and temazepam, which also contribute to the drug's effects. Regarding excretion, these metabolites are primarily eliminated via the urine, mainly as oxidized and glucuronide conjugates. Less than 1% is excreted unchanged. The clearance rate is between 0.32 and 0.44 milliliters per minute per kilogram, and the elimination half-life ranges from 20 to 40 hours, which explains its prolonged effects. Now, turning to lorazepam, we use it mainly for short-term anxiety management, as a hypnotic to aid sleep, premedication before procedures, and importantly, for treating status epilepticus, which is a medical emergency. Chemically, lorazepam is a hydroxybenzodiazepine, and it comes in convenient forms, either as 1 or 2.5 milligram tablets or as a clear, colorless solution for injection, containing 4 milligrams per milliliter. By understanding these key pharmacokinetic and clinical points, we can better appreciate how these drugs are used effectively and safely within their therapeutic contexts. Let's take a closer look at the main actions of benzodiazepines. They include hypnosis, sedation, anxiolysis, anterograde amnesia, anticonvulsant effects, and muscular relaxation. These actions make benzodiazepines quite versatile in clinical use, especially in anesthesia and sedation protocols. Moving on to their mode of action, benzodiazepines work by targeting specific receptors known as benzodiazepine receptors. These are located at synapses throughout the central nervous system, particularly in the cortex and midbrain. These receptors are closely linked with GABA receptors, which are the main inhibitory neurotransmitter receptors in the brain. When benzodiazepines activate these receptors, they facilitate GABA activity, leading to increased chloride ion flow through channels. This hyperpolarizes the neuron, making it less likely to fire, which produces their calming and sedative effects. Regarding routes of administration, for adults, the typical oral or sublingual dose ranges from 1 to 4 milligrams per day, divided into smaller doses. When administered intravenously or intramuscularly, the dose is usually around 0.025 to 0.05 milligrams per kilogram. It's important to note that intramuscular injections can be quite painful, so they are used cautiously. Now, let's discuss the effects of benzodiazepines, starting with the cardiovascular system. Lorazepam, for example, generally does not have direct effects on the heart, which is a significant advantage in many clinical situations. In the respiratory system, mild depression of breathing can occur, but this is mainly of concern in patients with pre-existing lung disease. In the central nervous system, benzodiazepines produce sedation, which helps calm anxious or agitated patients, along with anterograde amnesia, meaning they have difficulty forming new memories during the period of drug action. They also have anticonvulsant properties, making them useful in seizure management. Finally, regarding the gastrointestinal system, lorazepam does not influence basal gastric acid secretion, which means it doesn't increase or decrease stomach acid production under normal conditions. Overall, benzodiazepines are powerful agents with multiple benefits, but understanding their specific actions, effects, and routes of administration helps us optimize their use safely and effectively. On this slide, we see that circulating cortisol and glucose levels tend to decrease when lorazepam is used as a premedication. This secondary effect is largely due to its anxiolytic properties, helping to reduce stress responses before procedures. When it comes to toxicity and side effects, it's important to remember that drowsiness, sedation, confusion, and impaired coordination can occur, and these are dose-dependent. So, higher doses increase the likelihood of these effects. Prolonged use of benzodiazepines like lorazepam can lead to tolerance, meaning you might need higher doses to achieve the same effect, and dependence, which can be problematic. If someone suddenly stops taking these drugs, especially after long-term use, they may experience acute withdrawal symptoms like insomnia, anxiety, confusion, or even psychosis. Now, looking at the pharmacokinetics, lorazepam has a high bioavailability, about 90%, when taken orally or intramuscularly, meaning most of the drug reaches systemic circulation. In terms of distribution, it binds strongly to plasma proteins, about 88 to 92%. Its volume of distribution is approximately 1 liter per kilogram, which influences how long the drug stays active in the body. Interestingly, lorazepam has a longer duration of action, but a shorter half-life of elimination compared to some other benzodiazepines. Regarding metabolism, lorazepam is conjugated directly in the liver to form an inactive water-soluble metabolite called glucuronide. This process makes it easier for the body to eliminate the drug. And speaking of elimination, around 80% of an oral dose is excreted in the urine as this glucuronide metabolite. The clearance rate is about 1 milliliter per minute per kilogram, and its half-life ranges from 8 to 25 hours. Importantly, this half-life isn't significantly affected by renal disease, which is useful to know when managing patients with kidney issues. Finally, shifting gears a bit, let's briefly touch on analgesics. These are drugs used specifically to manage and treat pain. Common examples include fentanyl, morphine, and pethidine, which are potent opioids used in various clinical settings to provide effective pain relief. Let's take a closer look at fentanyl. It has several important uses in medicine. First, it's used as the analgesic component during general anesthesia to manage pain effectively. Second, it provides pain relief during labor, especially when regional anesthesia is involved. It's also employed in premedication to prepare patients for surgery and in palliative care to help manage severe pain in terminal conditions. Chemically, fentanyl is a synthetic compound. classified as a tertiary amine and a derivative of phenylpiperidine. When it comes to presentation, it's available as a clear, colorless solution for injection containing 50 micrograms per milliliter of fentanyl citrate. There are also transdermal patches that deliver doses ranging from 12 to 100 micrograms per hour over a 72-hour period, which is useful for sustained pain control. Additionally, there are sublingual tablets available in various strengths from 100 to 800 micrograms. The main actions of fentanyl are analgesia, that's pain relief, and respiratory depression, which is an important effect to monitor closely. Its mode of action involves being a highly selective mu-opioid receptor agonist, often called a MOPI agonist. These receptors are key players in mediating pain relief. Opioids like fentanyl exert their effects by interacting with presynaptic G protein receptors. This interaction causes hyperpolarization of the nerve cell membrane by increasing potassium conductance, which decreases nerve excitability. As a result, both pre- and postsynaptic responses are dampened, contributing to its potent analgesic effect. When it comes to administration, in adults, the typical dose for premedication via intramuscular injection is between 50 and 100 micrograms. For induction, or to supplement general anesthesia, the intravenous dose can range from 1 to 100 micrograms per kilogram, depending on the situation. It's important to tailor the dose carefully to ensure effective pain management while minimizing side effects. Fentanyl can be given through several routes, including intravenous infusion, epidural, and spinal methods, which makes it quite versatile in different clinical settings. When administered intravenously, it acts very rapidly, usually within 2 to 5 minutes, thanks to its high lipid solubility. This quick onset is especially useful during surgeries or procedures. A small dose of fentanyl can last around 30 to 60 minutes, but if you give higher doses, say over 50 micrograms per kilogram, it can provide pain relief for 4 to 6 hours. Now let's talk about the effects, starting with the cardiovascular system. The most notable effect is bradycardia, or a slowing of the heart rate. Interestingly, fentanyl also blunts the body's normal cardiovascular responses to laryngoscopy and intubation, which can help stabilize the patient during airway management. Moving to the respiratory system, fentanyl is a potent respiratory depressant. It decreases both the respiratory rate and tidal volume, so we need to monitor patients closely. It also has strong antitussive properties, meaning it suppresses cough effectively. However, a rare but serious side effect is chest wall rigidity, sometimes called the wooden chest phenomenon, which can occur after fentanyl administration. Fortunately, fentanyl causes minimal histamine release, so bronchospasm is rarely a concern with its use. In the central nervous system, fentanyl is remarkably potent, 50 to 80 times more potent as an analgesic than morphine. Interestingly, it doesn't cause much sedation or hypnosis on its own. There have been some reports of seizure-like activity in patients receiving fentanyl, so that's something to keep in mind. Regarding the autonomic system, fentanyl reduces gastrointestinal motility and decreases gastric acid secretion, which can be beneficial in certain surgical scenarios. It also increases the tone of the ureters, bladder detrusor muscle, and the vesicular sphincter, influencing urinary function. On the metabolic side, high doses of fentanyl can blunt the stress response to surgery, helping to stabilize metabolic parameters during extensive procedures. Of course, we must be aware of potential toxicity and side effects. Post-operative respiratory depression is a significant concern, and patients may also experience nausea, vomiting, and, in some cases, dependence. So, careful monitoring and appropriate dosing are essential to maximize benefits and minimize risks. Let's talk about the kinetics of fentanyl first. When taken orally, fentanyl is absorbed, but its bioavailability is only about 33%. This limited absorption is mainly because, in the stomach, fentanyl becomes highly ionized, around 99.9%, which slows down how much of it actually gets into the bloodstream. On the other hand, transdermal delivery offers a different profile. about 47% absorption at 24 hours, increasing to 88% at 48 hours, and reaching 94% by 72 hours. Moving on to distribution, fentanyl is quite highly bound to plasma proteins, between 81 and 94%, and its volume of distribution ranges from 0.88 to 4.41 liters per kilogram. Because of its short duration of action after a single dose, redistribution plays a key role here. Fentanyl is more lipid-soluble than morphine, which allows it to cross the blood-brain barrier more easily. This property results in a quicker onset of action compared to morphine. When it comes to metabolism, fentanyl is primarily processed in the liver through N-dealkylation to norfentanyl, followed by hydroxylation. It can also undergo hydroxylation and amide hydrolysis. From there, the drug and its metabolites are mainly eliminated via the urine. About 10% of the dose is excreted unchanged, with clearance around 13 milliliters per kilogram per minute. The elimination half-life varies quite a bit, from roughly 141 to 853 minutes. Now, shifting gears to morphine, it's a phenanthrene derivative used in several important clinical scenarios. It's commonly used for premedication, managing moderate to severe pain, treating left ventricular failure, and providing analgesia during terminal care. Its versatility makes it a cornerstone in pain management. So, in summary, fentanyl and morphine differ significantly in their absorption, distribution, metabolism, and excretion, but both are vital in our arsenal for pain control and other clinical uses. Today, we're looking at the different forms in which morphine can be administered. It comes as tablets of various strengths, including 5, 10, 30, 60, 100, and 200 milligrams. It's also available as a syrup with concentrations of 2, 10, or 20 milligrams per milliliter, as suppositories of 15 or 30 milligrams, and as a clear, colorless solution for injection, which can contain 10, 15, or 30 milligrams per milliliter of morphine sulfate. It's important to remember that preservative-free morphine must be used for epidural or spinal administration to prevent any adverse reactions. Moving on to the main actions of morphine, it primarily provides pain relief or analgesia, but it also has the potential to depress respiration, which is a critical point to monitor in clinical practice. Now, let's discuss how morphine works. It acts as an agonist at both mu and kappa opioid receptors in the nervous system. Opioids like morphine increase intracellular calcium levels, which then enhances potassium conductance. This process hyperpolarizes the cell membranes, making nerve cells less excitable. Essentially, this decrease in membrane excitability dampens both pre- and postsynaptic responses, leading to effective pain relief, but also the potential for respiratory depression. Regarding routes of administration and dosing, the starting oral dose for adults is typically between 5 and 20 milligrams every 4 hours, with adjustments made based on the patient's response. For rectal administration, doses range from 15 to 30 milligrams every 4 hours. Intramuscular or subcutaneous injections are given at 0.1 to 0.2 milligrams per kilogram, while intravenous doses are slightly lower, at 0.05 to 0.1 milligrams per kilogram, every 3 to 4 hours. For spinal or epidural use, intrathecal doses of 0.2 to 1 milligram are recommended. After intramuscular injection, the peak analgesic effect usually occurs within 30 to 60 minutes, lasting around 3 to 4 hours. Finally, let's look at the cardiovascular effects. Morphine generally has minimal impact on the cardiovascular system, but the most common effect is orthostatic hypotension, which results from a decrease in systemic vascular resistance. In high doses, it can also cause bradycardia or a slow heart rate, so careful monitoring is essential when administering larger quantities. Understanding these key points helps us appreciate how morphine functions and how to use it safely and effectively in patient care. Let's start by looking at the respiratory effects of morphine. It can cause respiratory depression, meaning it decreases the ventilatory response to hypoxia and hypercapnia. So, in simpler terms, it reduces the body's natural drive to breathe when oxygen levels are low or carbon dioxide levels are high. Additionally, morphine has a strong antitussive action, which means it suppresses cough. However, at high doses, it can lead to bronchoconstriction, narrowing the airways, which is important to keep in mind, especially for patients with respiratory issues. Moving on to the central nervous system effects, morphine is well known as a potent analgesic, great for pain relief. But it also causes drowsiness, helps relieve anxiety, and can produce euphoria. That said, high doses may lead to seizures or muscular rigidity, so dosing needs careful monitoring. Now, regarding the gastrointestinal system, morphine decreases gut motility, which can lead to constipation. It also reduces gastric acid, biliary, and pancreatic secretions, which can affect digestion. Moreover, it causes spasm of the sphincter of Oddi, increasing pressure in the common bile duct. Patients might experience nausea, vomiting, or constipation as side effects. In terms of the genitourinary system, morphine increases the tone of the ureters, bladder detrusor muscle, and sphincter. This heightened tone can lead to urinary retention, which is important to be aware of in clinical settings. Now, let's discuss some of the metabolic and other effects. Morphine can cause mild diaphoresis and itching, or pruritus, due to histamine release. It also stimulates the secretion of antidiuretic hormone, or ADH, which can impair water excretion and lead to hyponatremia, low sodium levels. Additionally, it causes a transient decrease in adrenal steroid secretion, which might have some hormonal implications. Turning to toxicity and side effects, the most concerning are respiratory depression, nausea, vomiting, hallucinations, and the risk of dependence. After epidural or spinal administration, pruritus can also occur. Finally, regarding pharmacokinetics, morphine is well absorbed when taken orally. However, its bioavailability is only about 15 to 50% due to extensive first-pass metabolism in the liver, meaning a significant portion is metabolized before reaching systemic circulation. This is an important consideration when choosing the route of administration and dosing. Overall, understanding these effects helps us use morphine safely and effectively, balancing its powerful analgesic benefits with potential side effects. Let's take a closer look at the pharmacokinetics of pethidine. The drug is about 20 to 40% protein-bound in the plasma, mainly to albumin, which is important because protein binding affects how much free drug is available to act. Its volume of distribution, or VD, ranges from 3.4 to 4.7 liters per kilogram, indicating how widely it disperses in body tissues. Moving on to metabolism, pethidine is processed in the liver where it forms several metabolites, including morphine 3-glucuronide, morphine 6-glucuronide, and normorphine. These metabolites can influence both the efficacy and side effects of the drug. Regarding excretion, most of the drug and its metabolites are eliminated through the urine as conjugated glucuronides. However, about 7 to 10% of the drug is excreted in the feces as conjugated morphine, which highlights the importance of renal function in clearance. The overall clearance rate of pethidine is between 12 and 23 milliliters per minute per kilogram, and its elimination half-life ranges from 1.7 to 4.5 hours. These parameters help us understand how quickly the drug is removed from the body, which is crucial for dosing and timing. Now, let's discuss its uses. Pethidine is versatile. It's used as premedication before procedures, as an analgesic to manage moderate to severe pain, and also as an antispasmodic in cases of renal and biliary colic. Chemically, it's a synthetic derivative of phenylpiperidine, which gives it its specific properties. It's usually presented as 50 mg tablets or as a clear, colorless solution for injection, containing 10 or 50 mg per milliliter of pethidine hydrochloride. Its main actions are analgesia and respiratory depression, which are typical of opioids. The mode of action involves binding to mu and kappa-opioid receptors, which are part of the body's pain regulation system. When these receptors are activated, they increase intracellular calcium levels, leading to greater potassium conductance and hyperpolarization of nerve cells. This process essentially dampens the transmission of pain signals and can also depress respiratory centers, which is important to monitor during use. Understanding these pharmacokinetic and pharmacodynamic properties helps us optimize the safe and effective use of pethidine in clinical practice. The decrease in membrane excitability that we see with pethidine can actually lead to reduced responses both pre- and postsynaptically, which affects how signals are transmitted across nerve cells. Moving on to routes of administration and doses, in adults, the oral dose is typically 50 to 150 milligrams every 4 hours. For intramuscular injection, the range is 25 to 150 milligrams, and intravenously it's 25 to 100 milligrams. Pethidine can also be given via the epidural route, usually around 25 milligrams. When administered orally, the drug acts within about 15 minutes, whereas intramuscular administration kicks in faster, within roughly 10 minutes. The effects generally last about 2 to 3 hours. Now let's discuss the effects. Starting with the cardiovascular system, or CVS, pethidine can cause orthostatic hypotension. This happens because it releases histamine and blocks alpha-adrenergic receptors, leading to blood vessel dilation and a drop in blood pressure when standing. It also has mild quinidine-like effects and anticholinergic properties, which can lead to an increased heart rate or tachycardia. Regarding the respiratory system, or RS, pethidine is a potent depressant. It affects tidal volume more significantly than respiratory rate, meaning it reduces the amount of air moved in and out of the lungs quite effectively. Chest wall rigidity is another concern, especially with higher doses, which can make breathing even more difficult. In the central nervous system, or CNS, pethidine is less potent than morphine, about 1/10 as strong as morphine in analgesic effect. Interestingly, it tends to produce more euphoria and causes less nausea and vomiting compared to morphine at equivalent doses. In the gastrointestinal system, or AS, pethidine decreases gastric emptying, which can affect digestion. It causes less increase in bile duct pressure and has less impact on intestinal activity, meaning it's less likely to cause constipation than morphine at similar doses. In the genitourinary system, or GU, the drug decreases ureteric tone, which could potentially influence urine flow. It may also increase the contractions of the uterus during pregnancy, which is an important consideration in obstetric cases. Finally, on the metabolic side, pethidine increases secretion of antidiuretic hormone, or ADH, and decreases adrenal steroid secretion. These hormonal effects can influence fluid balance and stress responses in the body. So overall, pethidine has a wide range of effects across different systems, and understanding these helps us use it safely and effectively in clinical practice. Let's take a look at some important considerations regarding pethidine. First, we need to be aware of its potential toxicity and side effects. Respiratory depression can occur, which is a serious concern, along with nausea and vomiting. Some patients may also experience hallucinations, and dependence is a risk that cannot be overlooked when using pethidine. Now, moving on to its pharmacokinetics, or how the drug moves through the body. When taken orally, pethidine's bioavailability ranges from about 45 to 75%, mainly because of a significant first-pass effect in the liver. However, if administered intramuscularly, directly into the deltoid muscle, it reaches 100% bioavailability, ensuring maximum effectiveness. Once in the bloodstream, pethidine distributes, with about 49 to 67% binding to plasma proteins. Its volume of distribution, or VD, is roughly 3.5 to 5.3 liters per kilogram, indicating how widely it spreads in the body. It's important to note that pethidine crosses the placenta, which has implications for use during pregnancy. Regarding metabolism, the liver plays a key role. Pethidine undergoes endemethylation to form norpethidine and hydrolysis to pethidinic acid. The metabolite norpethidine can accumulate, especially in cases of renal failure, potentially leading to toxicity. For excretion, only about 1 to 25% of the drug is excreted unchanged in the urine. depending on urinary pH. Norpithidine is also eliminated via the kidneys, but accumulation may happen if there's renal or hepatic impairment. The overall clearance rate is between 12 to 22 milliliters per minute per kilogram, with an elimination half-life of approximately 2.4 to 7 hours. Now, shifting gears a bit, let's talk about antipyretics. These are drugs used specifically to reduce fever. One common example is paracetamol, which is widely used not only as an analgesic for mild to moderate pain, but also as an antipyretic agent. So, whether you're dealing with pain relief or fever reduction, paracetamol plays a significant role in clinical practice. Let's take a closer look at the chemical nature of this drug. It is an acetanilide derivative, which is important for understanding its pharmacological profile. Now, in terms of presentation, this medication comes in several forms. It's available as tablets and suppositories, with doses ranging from 60, 125, 250 to 500 milligrams of paracetamol. Additionally, there's a syrup formulation containing 24 or 50 milligrams per milliliter for easier administration, especially in children. For intravenous use, there's an infusion preparation with a concentration of 10 milligrams per milliliter, supplied in 50 and 100 milliliter vials. The key point here is that the drug should be infused over about 15 minutes to ensure safety and effectiveness. There's also an intravenous prodrug called propacetamol, where 1 gram of it is equivalent to 500 milligrams of paracetamol. This offers an alternative route, especially useful in certain clinical scenarios. Moving on to the main action, paracetamol primarily acts as an analgesic and antipyretic. It's effective in relieving pain and reducing fever, which are common reasons for its use. Now, the mode of action is a bit complex and not fully understood, but we do know that it inhibits the cyclooxygenase enzymes, CoX1 and CoX2. Interestingly, it mainly affects areas of low inflammation, unlike NSAIDs that target more inflamed tissues. Prostaglandin synthesis within the central nervous system is also inhibited, which explains its antipyretic effect. Specifically, it blocks the production of E-series prostaglandins in the anterior hypothalamus, especially in response to pyrogens, the substances that cause fever. Regarding routes of administration and dosing, adults and adolescents over 50 kilograms typically take 500 milligrams to 1 gram every 4 to 6 hours, with a maximum daily dose of 4 grams. This applies to oral, rectal, and intravenous routes. For children, the doses are weight-based, ranging from 60 to 90 milligrams per kilogram per day, divided into doses depending on age and route. Neonates require lower doses, around 30 to 60 milligrams per kilogram per day, also divided. Overall, understanding these formulations and dosing guidelines helps us ensure safe and effective use of paracetamol in various patient populations. Let's take a closer look at the effects of paracetamol. First, in terms of the central nervous system, it's notable that the maximum analgesic effect of paracetamol actually surpasses that of any other non-opioid analgesic. This highlights its potency in pain relief. Moving to absorption, paracetamol is often used as a model for studying drug absorption, because its rate of absorption is directly proportional to gastric emptying. So, any factors that influence gastric emptying, like other drugs, can alter how quickly paracetamol is absorbed. Interestingly, paracetamol itself doesn't affect the liver unless taken in overdose, and it doesn't cause gastric ulcers, making it relatively safe in that regard. Now, looking at its metabolic and other effects, paracetamol can enhance the effect of antidiuretic hormone, or ADH. It also has a dose-dependent influence on platelets, and this inhibition can sometimes lead to bleeding issues that are clinically significant. Regarding toxicity and side effects, even at therapeutic doses, some patients might experience gastrointestinal disturbances, skin reactions, or blood disorders such as thrombocytopenia or neutropenia. Additionally, about 5% of individuals allergic to aspirin may also show cross-sensitivity to paracetamol. Let's discuss its kinetics now. When taken orally, paracetamol is rapidly absorbed from the upper GI tract, with bioavailability ranging from 63 to 89% because of first-pass metabolism. When administered rectally, absorption varies more. Bioavailability can be anywhere from 24 to 98%, depending on the individual. In terms of distribution, paracetamol isn't highly protein-bound, only about 0 to 5% in plasma, and has a volume of distribution between 0.7 and 1 liter per kilogram. Since it's lipid-soluble, it penetrates tissues well, including the blood-brain barrier, and it can cross the placenta. Finally, regarding metabolism, most of the drug is processed in the liver. About 80 to 90% is metabolized into conjugates, glucuronide making up 60 to 80%, and sulfate 20 to 30%. A smaller portion, around 10%, is metabolized via the cytochrome P450 system, specifically CYP2E1. Understanding these aspects helps us appreciate how paracetamol works, its safety profile, and how various factors can influence its effectiveness and risks. Let's start by discussing excretion. Typically, only about 1 to 5% of the drug is excreted unchanged in the urine. The metabolites, such as glucuronides and sulfates, are actively secreted in the renal tubules at low concentrations. But interestingly, they are reabsorbed actively when their concentrations are high. The overall clearance rate for this process is around 5 milliliters per kilogram per minute. In terms of elimination half-life, it generally ranges from 2 to 4 hours in normal adults, slightly longer in neonates at 4 to 5 hours, and can extend up to 11 hours in premature neonates. This highlights how age and developmental stage influence drug metabolism and clearance. Moving on to nonsteroidal anti-inflammatory drugs, or NSAIDs, these are commonly used medications that help relieve pain, reduce inflammation, and lower high temperatures or fevers. Some well-known NSAIDs include ibuprofen, diclofenac, aspirin, and tramadol. Focusing on ibuprofen specifically, it's used in a variety of clinical situations. For example, it's effective in treating rheumatoid arthritis and osteoarthritis, which are chronic joint conditions involving inflammation. It's also helpful for musculoskeletal disorders, which can cause pain and stiffness. Additionally, ibuprofen is often used to manage dysmenorrhea or painful menstrual cramps. It's beneficial in migraine relief as well, providing pain relief during headaches. Moreover, ibuprofen can be used post-surgery as an adjunct to other pain medications, including opioids, to help manage post-operative pain. And finally, it's frequently used as an antipyretic, meaning it helps reduce fever. So, in summary, ibuprofen is a versatile NSAID that plays a significant role in managing pain, inflammation, and fever across various medical conditions. Today, I want to talk about ibuprofen, which is a derivative of a phenylpropanoic acid. As you know, it's a very common medication with a variety of forms available. You can find it as capsules, tablets, suspensions, suppositories, and even topical gels. This versatility makes it accessible for different patient needs and preferences. Now, moving on to its main actions. Ibuprofen is primarily known as an analgesic, meaning it helps reduce pain. It's also anti-inflammatory, so it can decrease swelling and inflammation, and it acts as an antipyretic, effectively reducing fever. These combined effects make it a go-to medication for many conditions involving pain and inflammation. Let's discuss how it works. Ibuprofen acts as a nonspecific inhibitor of the cyclooxygenase enzymes, or COX enzymes. These enzymes convert arachidonic acid into cyclic endoperoxidases, which then lead to the production of prostaglandins, thromboxanes, and prostacyclin. By inhibiting COX, ibuprofen prevents the formation of these molecules. Prostaglandins, in particular, play a key role in sensitizing peripheral pain receptors to noxious stimuli, which explains why blocking their synthesis reduces pain and inflammation. Regarding administration, the typical adult oral dose ranges from 1,200 to 1,800 milligrams daily, divided into smaller doses throughout the day. In more severe cases, the dose can go up to 2,400 milligrams daily. For children, The dosing is usually around 20 milligrams per kilogram, also divided into doses. Besides oral intake, ibuprofen can be administered rectally or applied topically, providing flexibility depending on the patient's needs. Now let's look at some effects and potential side effects. In asthmatic patients, about 20% may experience bronchoconstriction, so caution is advised there. Common gastrointestinal side effects include dyspepsia, nausea, bleeding from gastric and duodenal vessels, mucosal ulcers, perforations, and diarrhea, all linked to its effect on CoX-1. Also, in patients with Crohn's disease or ulcerative colitis, ibuprofen might worsen their condition. Lastly, on a metabolic level, ibuprofen reduces platelet aggregation, which can affect blood clotting. This is an important consideration, especially in patients at risk of bleeding or those taking other blood-thinning medications. So, overall, ibuprofen is a versatile drug with multiple forms and benefits, but it's important to be aware of its side effects and contraindications to use it safely and effectively. Let's discuss some important safety considerations. Toxicity and side effects are common, especially disturbances of the gastrointestinal system, which many patients experience. Rashes and impairments in the liver, kidneys, and blood cells have also been reported. It's important to remember that with prolonged use of NSAIDs, like ibuprofen, there is a risk of developing analgesic nephropathy, which involves damage to the kidney's papillary tissue and interstitial fibrosis. Now, moving on to the pharmacokinetics of ibuprofen. When taken, about 80% of the drug is absorbed into the bloodstream, so it has good bioavailability. In the plasma, it binds heavily, between 90 and 99%, to albumin, which affects how the drug is distributed throughout the body. Its volume of distribution is roughly 0.14 liters per kilogram, indicating it mostly stays in the blood and extracellular fluids. Interestingly, ibuprofen can cross the placenta, so caution is needed during pregnancy. Regarding metabolism, ibuprofen is processed in the liver through oxidation, resulting in 2 inactive metabolites. The drug is then excreted via the urine, and it has a half-life of about 2 hours, meaning it's cleared relatively quickly from the body. Now let's turn to diclofenac. It's used in a variety of conditions, such as rheumatoid arthritis and osteoarthritis, which are chronic inflammatory diseases. It's also effective for musculoskeletal disorders and dysmenorrhea, which is painful menstruation. Additionally, diclofenac is helpful for managing minor post-surgical pain and is often used alongside opioids to enhance pain relief. It also serves as an antipyretic, helping to reduce fever, and in eye surgery, it's used to inhibit meiosis and control inflammation after cataracts. Chemical-wise, diclofenac is a phenylacetic acid derivative, which is important because it influences its mechanism of action and pharmacological profile. Overall, understanding these key points helps us optimize the safe and effective use of these drugs in clinical practice. Now, let's look at the different forms in which diclofenac sodium is available. It comes as 25, 50, and 100 milligram tablets, and also as suppositories in 12.5, 25, 50, and 100 milligrams. Additionally, it can be administered via ampules containing either 25 milligrams per milliliter or 75 milligrams per 2 milliliters for injection. Moving on to its main actions, diclofenac is primarily used as an analgesic to relieve pain, an anti-inflammatory to reduce swelling and inflammation, and an antipyretic to lower fever. Now, regarding how it works, diclofenac is a nonspecific inhibitor of cyclooxygenase enzymes, or COX enzymes. It inhibits both COX-1 and COX-2 in a ratio of about 1:1. These enzymes are responsible for converting arachidonic acid into cyclic endoperoxidases. By doing this, diclofenac prevents the formation of prostaglandins, thromboxanes, and prostacyclin, key mediators involved in pain, inflammation, and fever. Specifically, prostaglandins play a role in sensitizing peripheral pain receptors to noxious stimuli, which is why blocking their formation helps reduce pain. When it comes to administration and dosing, the typical adult oral dose ranges from 75 to 150 milligrams per day, divided into smaller doses throughout the day. For rectal administration, the dose is usually 100 milligrams, either as suppositories or tablets, with a maximum of 150 milligrams in 24 hours. It can also be given before or during surgery to manage pain. For intramuscular use, the dose is generally 75 milligrams once or twice daily. In children, the dose is calculated at about 1 milligram per kilogram, taken 3 times a day. For intravenous administration, doses range from 25 to 75 milligrams, with a maximum daily limit of 150 milligrams. Finally, let's consider some effects and side effects. Diclofenac tends to cause less gastrointestinal damage than aspirin, but some issues can still occur. Common gastrointestinal side effects include dyspepsia, nausea, bleeding from gastric and duodenal vessels, mucosal ulcers, perforation, and diarrhea. It's important to note that it may worsen conditions in patients with Crohn's disease or ulcerative colitis. In patients with asthma, up to 20% may experience bronchoconstriction or eosinophilia, which is an increase in certain white blood cells. On the renal side, diclofenac reduces plasma renin activity and aldosterone concentrations by about 60 to 70%, which can influence blood pressure regulation and fluid balance. So, understanding these aspects helps us appreciate how diclofenac is used effectively while being mindful of its potential side effects and the importance of appropriate dosing. Now, let's look at some of the metabolic and other effects of diclofenac. Interestingly, it interferes with neutrophil function, which is part of the immune response. It also reversibly inhibits platelet aggregation, meaning it can prevent platelets from clumping together. But importantly, it doesn't affect bleeding time or other clotting factors like prothrombin time or plasma fibrinogen. This suggests it has a specific effect on platelets without significantly increasing bleeding risk. Moving on to toxicity and side effects, about 12% of patients may experience adverse effects. These are often related to how long the drug is used, with risks increasing notably after more than 5 days of continuous therapy, especially in elderly patients. Gastrointestinal disturbances and central nervous system issues can sometimes occur. Rashes, liver, kidney, and blood-related problems have also been reported. Intramuscular injections can sometimes be painful and may lead to sterile abscesses. Additionally, since diclofenac can inhibit uterine contractions, caution is needed in pregnancy. Now, let's talk about how the drug moves through the body, starting with absorption. Diclofenac is well absorbed from all routes of administration, with about 60% bioavailability when taken orally. It binds strongly to plasma proteins, about 99.5%, mainly albumin, which affects its distribution. The volume of distribution is relatively small, around 0.12 to 0.17 liters per kilogram, and it can cross the placenta. Once in the body, diclofenac enters the synovial fluid in joints, reaching peak concentrations about 2 to 4 hours after the plasma peaks. The levels in synovial fluid can remain high for up to 12 hours, which is helpful for managing joint pain. The drug is then eliminated with a half-life of roughly 3 to 6 hours. Regarding metabolism, diclofenac undergoes significant first-pass metabolism in the liver, where it's hydroxylated and methoxylated to create phenolic metabolites. About 65% of the dose is excreted in urine, with the remaining 35% in bile, and less than 1% is excreted unchanged. Its clearance is around 263 milliliters per minute, and the plasma half-life for elimination is generally between 1 and 2 hours. Understanding these pharmacokinetic properties helps us appreciate how diclofenac is processed in the body and guides us in dosing and monitoring for safety. Let's take a closer look at tramadol. It is primarily used to manage moderate to severe pain, making it a valuable option in many clinical situations. Chemically, it's a synthetic opioid that belongs to the aminocyclohexanol group. When it comes to presentation, tramadol is available as a clear aqueous solution for injection, containing 50 mg per milliliter, as well as tablets that come in various dosages: 50, 100, 150, 200, 300, and 400 milligrams of tramadol hydrochloride. The main action of tramadol is centrally mediated analgesia, meaning it works within the brain and spinal cord to relieve pain. Its mode of action involves being a non-selective agonist at multiple opioid receptors, mu, kappa, and delta. This broad receptor activity helps explain its effectiveness in pain relief. In terms of administration, tramadol can be given orally, intramuscularly, or via slow intravenous injection or infusion. For adults, the typical dose ranges from 50 to 100 milligrams every 4 to 6 hours, depending on the need. For children, the dose is calculated based on weight, 1 to 2 milligrams per kilogram, also given every 4 to 6 hours. Now, regarding its effects, tramadol has minimal impact on the cardiovascular system when given intravenously. It doesn't cause significant changes in blood pressure or heart rate. Similarly, it doesn't substantially alter respiratory parameters. The respiratory rate, minute volume, and carbon dioxide levels remain stable after therapeutic doses. In the central nervous system, tramadol's analgesic potency is roughly equivalent to pethidine, another opioid. Interestingly, only about 30% of its effect is reversed by naloxone, which indicates that part of its pain-relieving action is not solely opioid receptor-mediated, but also involves other pathways. So, in summary, tramadol is a versatile analgesic with a unique receptor profile, offering effective pain relief with a relatively favorable safety profile when used appropriately. Tramadol, interestingly, doesn't seem to have any significant effect on bile duct sphincter activity, which is good to know when considering its use in patients with biliary issues. Also, unlike some opioids, constipation is quite rare with tramadol, making it a more tolerable option for many patients. Now, moving on to its side effects, the most common ones are nausea, dizziness, and sedation. These are important to monitor, especially in patients who might be more sensitive or on other sedative medications. When we look at the kinetics, the absorption of tramadol is quite efficient. Following oral administration, its bioavailability ranges from about 68 to 100%, meaning most of it gets into the bloodstream. In terms of distribution, roughly 20% of the drug binds to plasma proteins, and its volume of distribution is between 2.9 and 4.37 liters per kilogram, indicating it distributes well throughout body tissues. Notably, about 80% of an administered dose crosses the placenta, which is something to consider during pregnancy. Metabolically, around 85% of tramadol is processed in the liver through demethylation, producing an active metabolite called O-desmethyltramadol. This contributes to its pain-relieving effects. For excretion, most of the drug, about 90%, is eliminated via the urine, with the remaining 10% in feces. Its clearance varies between 6.7 and 10.1 milliliters per kilogram per minute, and the half-life ranges from roughly 270 to 450 minutes. Importantly, in patients with impaired renal or hepatic function, this half-life can double, which means the drug stays in the system longer and requires careful dose adjustments. Shifting gears to steroids, these are primarily used to reduce inflammation, allergies, and manage inflammatory bowel diseases. Common drugs include hydrocortisone and methylprednisolone, which are essential tools in our therapeutic arsenal for controlling excessive inflammatory responses. Hydrocortisone is a versatile medication, primarily used in several key areas. It acts as a replacement therapy in cases of adrenocortical deficiency, helping to restore hormone levels when the adrenal glands aren't producing enough. It's also used to treat allergic reactions and severe allergic responses like anaphylaxis, providing rapid relief. Additionally, it's beneficial in managing asthma by reducing airway inflammation. And finally, it's used for immunosuppression, especially after organ transplants, to prevent rejection. Chemically, hydrocortisone is classified as a glucocorticosteroid, which means it has potent anti-inflammatory properties. When we look at its presentation, you'll find it as 10 or 20 milligram tablets, or in vials containing a white lyophilized powder. To prepare it for injection, This powder is reconstituted with water to produce a solution containing 100 milligrams of hydrocortisone sodium succinate. The main action of hydrocortisone is its anti-inflammatory effect. It works by controlling the rate of protein synthesis within cells. Essentially, it reacts with cytoplasmic receptors to form a complex that influences the transcription of RNA, leading to the synthesis of anti-inflammatory proteins called lipocortins. Regarding how we administer it, the routes and doses vary depending on the condition. For adults, intravenous doses typically range from 100 to 500 milligrams every 6 to 8 hours. When given IV, it starts working within 2 to 4 hours and lasts around 8 hours. For oral use, the dose is usually between 10 to 20 milligrams per day, and we aim to use the lowest effective dose, ideally on alternate days to minimize side effects. Intra-articular injections are also common, with doses ranging from 5 to 50 milligrams daily, depending on the condition being treated. Overall, understanding how hydrocortisone works and how it's administered helps us optimize its use for various inflammatory and immune-related conditions, fitting into our broader goal of managing these complex health issues effectively. Let's discuss the effects of corticosteroids across various body systems. Starting with the cardiovascular system, in the absence of these steroids, we see increased vascular permeability, which can lead to fluid leakage. Small blood vessels also have an inadequate motor response, and overall, cardiac output tends to decrease. However, when corticosteroids are administered, they have a positive effect on the heart's ability to contract and cause vasoconstriction. This is because they increase the number of alpha-1 and beta adrenoreceptors and stimulate their function, helping to maintain blood pressure and perfusion. Moving to the central nervous system, corticosteroids actually increase neural excitability. Without enough glucocorticoids, individuals might experience symptoms like apathy, depression, or irritability, highlighting how important these hormones are for mood and mental function. In the adrenal system, or AS, hydrocortisone specifically can increase the risk of peptic ulcer disease. It also decreases calcium absorption in the gastrointestinal tract, which can affect bone health over time. Regarding the genitourinary system, hydrocortisone has weak mineralocorticoid effects. It promotes sodium retention and increases potassium excretion, which can influence fluid balance and blood pressure. Additionally, it increases calcium excretion through the urine, and it boosts the glomerular filtration rate and stimulates tubular secretory activity, affecting kidney function overall. In terms of metabolism and other effects, hydrocortisone profoundly impacts carbohydrate, protein, and lipid metabolism. It stimulates gluconeogenesis, the process of producing glucose from non-carbohydrate sources, and inhibits peripheral glucose utilization, which can raise blood sugar levels. As a potent anti-inflammatory agent, it inhibits all stages of inflammation by preventing neutrophil and macrophage recruitment, thereby reducing tissue damage. Corticosteroids also increase the levels of red blood cells, neutrophils, and hemoglobin, contributing to their effects on blood composition. Finally, let's touch on toxicity and side effects. These include acute withdrawal syndrome if the drug is stopped suddenly, as well as Cushing's syndrome, which results from prolonged use of excessive corticosteroids. Cushing's syndrome presents with characteristic features like central obesity, a moon face, buffalo hump, striae, acne, hirsutism, and increased skin and capillary fragility. Recognizing these effects is crucial when managing corticosteroid therapy, ensuring we balance their benefits with potential risks. In addition to these effects, we should be aware of some metabolic derangements that can occur with corticosteroid use. These include altered glucose tolerance, fluid retention, a hypokalemic alkalosis, and even osteoporosis over time. There are also some complications that might arise, such as proximal myopathy, cataracts, and an increased susceptibility to peptic ulcer disease. These are important to keep in mind when managing patients on these medications. Now let's talk about the kinetics of hydrocortisone. When taken orally or rectally, hydrocortisone is well absorbed. Its oral bioavailability is about 54%, meaning roughly half of the dose reaches systemic circulation, while rectal absorption can vary quite a bit, from 30% up to 90%. In terms of distribution, most of the drug binds reversibly in the plasma, about 20% to albumin and 70% to a specific corticosteroid-binding globulin. At low concentrations, around 90% of hydrocortisone is protein-bound, but at higher doses, this drops to about 60–70%. The volume of distribution ranges from 0.3 to 0.5 liters per kilogram, depending on the dose. When it comes to metabolism, hydrocortisone is processed primarily in the liver, where it's converted into tetrahydrocortisone. As for excretion, its clearance rate is dose-dependent, ranging from 167 to 283 milliliters per minute, and its elimination half-life is relatively short, between 1.2 and 1.8 hours. Switching gears to methylprednisolone, particularly prednisolone, which we use in various clinical scenarios. It's mainly employed as a replacement therapy in cases of adrenocortical deficiency, but also in allergic reactions, anaphylaxis, hypercalcemia, and asthma. Its versatility makes it a key tool in our therapeutic arsenal. Let's take a closer look at some specific uses of prednisolone. It can be used for certain types of red eye inflammation, which are often caused by allergic or other inflammatory responses. Additionally, it plays a role in managing leukemia, especially during chemotherapy when controlling inflammation and immune responses is crucial. Another important application is in preventing organ rejection, where immunosuppression is necessary to help the body accept a transplanted organ. Now, regarding the chemical itself, prednisolone is a synthetic glucocorticosteroid. It comes in various forms, tablets of 1, 2.5, 5, and 20 milligrams, as well as injectable solutions with 25 milligrams per milliliter of prednisolone acetate, and even as eye or ear drops for local application. Its main action is anti-inflammatory, which helps reduce swelling, redness, and other inflammatory symptoms. The mode of action involves controlling protein synthesis. Corticosteroids bind to receptors in the cytoplasm, forming a complex that directly influences RNA transcription. This process promotes the synthesis of proteins called lipocortins, which help suppress inflammatory responses. As for routes of administration, adults typically take between 5 and 60 milligrams daily, divided into doses, starting at the lowest effective dose, and sometimes on alternate days to minimize side effects. For injections, the dose ranges from 25 to 100 milligrams, given once or twice a week, either intramuscularly or directly into a joint. Now, let's briefly discuss the effects on the cardiovascular system. Without corticosteroids, we see increased vascular permeability, which can lead to swelling and edema. Small blood vessels might not respond properly to signals, and overall, cardiac output can decrease. This highlights how important corticosteroids are in maintaining vascular and cardiac stability during inflammation or immune suppression. Steroids have a notable positive effect on myocardial contractility, meaning they can help the heart pump more effectively. They also cause vasoconstriction, which is the narrowing of blood vessels, by increasing the number and activity of alpha-1 and beta-adrenoreceptors. Moving to the central nervous system, corticosteroids actually increase the excitability of the nerves. However, if there's a deficiency of glucocorticoids, it can lead to symptoms like apathy, depression, and irritability. In the adrenal system, prednisolone is known to increase the risk of peptic ulcer disease. It also decreases calcium absorption in the gastrointestinal tract, which can impact bone health. Regarding the genitourinary system, prednisolone has weak mineralocorticoid effects. This means it can cause sodium retention and potassium loss, and it also increases calcium excretion in the urine. Additionally, it boosts the glomerular filtration rate and stimulates the activity of the kidney tubules, affecting how the body handles fluids and electrolytes. When it comes to metabolism, prednisolone influences carbohydrate, protein, and fat metabolism. It stimulates gluconeogenesis, which is the production of glucose from non-carbohydrate sources, and it inhibits the utilization of glucose in peripheral tissues. Because of its anti-inflammatory properties, prednisolone inhibits all stages of inflammation by preventing neutrophil and macrophage recruitment. It also increases the concentrations of red blood cells, neutrophils, and hemoglobin, which can be beneficial in some conditions. However, there are significant side effects and toxicities to be aware of. Sudden withdrawal can cause an acute syndrome, and prolonged use of high doses can lead to Cushing's syndrome. This syndrome has characteristic features like central obesity, a moon face, buffalo hump, striae, acne, hirsutism, and fragile skin and capillaries. It can also cause metabolic issues such as impaired glucose tolerance, fluid retention, hypokalemic alkalosis, and osteoporosis. Other complications include proximal muscle weakness, cataracts, mood changes like mania, and an increased susceptibility to peptic ulcers. Understanding these effects helps us appreciate both the therapeutic benefits and the potential risks associated with corticosteroid use. Let's now look at the kinetics of prednisolone, which are crucial for understanding how the drug works in the body. First, absorption. Prednisolone is quickly and completely absorbed whether given orally or rectally. In fact, its bioavailability through either route ranges from 80 to 100%, meaning most of the drug reaches systemic circulation effectively. Moving on to distribution, once in the bloodstream, prednisolone binds reversibly to plasma proteins like albumin and a specific corticosteroid-binding globulin. At lower concentrations, about 80 to 90% of the drug is protein-bound, which helps regulate its activity. However, at higher concentrations, the protein binding drops to around 60 to 70%. The volume of distribution, or VD, varies from 0.35 to 0.7 liters per kilogram, depending on the dose, reflecting how the drug disperses into body tissues. Regarding metabolism, prednisolone is processed primarily in the liver through hydroxylation, followed by conjugation. This metabolic transformation is key for preparing the drug for excretion. Speaking of excretion, about 11 to 14% of the dose is excreted unchanged in the urine, while the rest is metabolized. The clearance rate, which indicates how efficiently the body eliminates the drug, depends on the dose and ranges between 170 and 200 milliliters per minute. Finally, the elimination half-life, which tells us how long it takes for half of the drug to be cleared from the body, is between 2.6 and 5 hours. All these kinetic parameters are essential because they influence dosing schedules and help us understand how long the drug's effects might last in different patients. Thank you so much for your time and attention today. I truly appreciate your engagement and interest in the topic. Remember, the key points we've covered highlight the importance of understanding the core concepts and applying them effectively. This presentation aimed to connect the dots between theory and practice, showing how these ideas can make a real difference. I hope you leave with new insights and a clearer path forward. Again, thank you for being such a wonderful audience.